Thank you so much for that lovely introduction, and it is a pleasure to be here with you this afternoon. Greetings from Ithaca. So I am a social and behavioral scientist. I'm an observer of human behavior, and as you heard just a moment ago, one of the things that I love about public health is the ability to be involved in any number of different important research areas. And one of the through lines in all of that work has been trying to understand how to work with different entities and the role that communication and trust play in all of those. So, like many of you, I wear many different hats, right? So, I have the research part of my life. I teach, I work with a ton of different community organizations, hospitals, academic and non academic partners. And what I'll be sharing today is the collection of not only my observations throughout these like closer to 17 years of work now, but also best practices across the social and behavioral sciences. So I may go all the way up to the end of the hour. I'm not sure, but I'll be sharing my email both now. So it's ALG52 at Cornell University, and I'll share it at the end. I always welcome questions, and I do put that up there for a reason. So what I'm going to start with today is just walking us through what we're going to go over in the next hour. I will focus both on kind of the abstract concepts and then really concrete examples and skills. So we're going to do a little bit of abstract work, but also make sure that this is very skills and practice based. I imagine there are folks here who have a range of different audiences. Some of you are involved more kind of at an individual level, maybe in a clinical role. Others of you are more in the public health space, so dealing with populations. My hope is that there are pieces of this that speak to everyone here. So we're going to start with the foundations of communication and behavior. We're going to have a big section on trust and why that is so important, and a little bit of what is going on in this particularly difficult moment in the US and also globally around trust in science and public health. We'll do a bit about learning about your audience and how that informs communication. We're going to do a very quick dive into theory behind effective communication. And I know sometimes people grumble a bit about the idea of having to do theoretical work, but I have tried to design this so it is really practical and lifts the veil a bit on some of what is going on in the background on how to be effective with different audiences. I'll then dip into strategies, and then we'll end with just a collection of resources. I'm always happy to provide more. And then questions if there's time. And if anybody wants a copy of the slides, I'm happy to share that with you. Just email me, or I can figure out a way to get a link to folks. So without further ado, here we go. So one of the first things that I want to start with, and I think is kind of foundational to any type of communication you're doing, is thinking about what are the goals around it. And I know, depending on what you went through in school, to inform, to educate, to entertain, to persuade, that is absolutely one way of thinking about it. I'm going to break it down into kind of three ways that I think might be more relevant for public health and medicine. I do think informing remains a really important part of communication. I would not necessarily say it's the most important part, but it's key. And I think there are elements here. So I'm going to kind of distinguish informing from persuading. So informing is when you're giving people information, you're updating them on the state of the science, on what's happening, and you are trying to facilitate independent decision making. You don't necessarily have a stake in what the outcome is. You're not trying to get someone to do anything in particular. You just want to make sure that they have the resources they need to make the decision. So I think that's kind of when you want folks to have information, but you're not vested in what their decision is. Often in public health, and I imagine also quite often in medicine, I'm not a clinician, so I don't want to speak for the group as a whole. We are in the business of what's called behavior change communication. We are trying to persuade people to do something specific, right? We want people to use insect repellent. We want people to get their screenings. We want people to think about their diet and smoking. We want people to vote, whatever it is. That is where, again, we're communicating with people, where we are trying to get them to do something in particular. And maybe that's to continue to do what they've always been doing, and we want that. Maybe it's to change. But that is that's quite different from just informing. And then the last one that I'm going to highlight is efforts around communication that are to engage people and build trust, right? This isn't necessarily in the moment to persuade anyone, to inform anyone about anything, but it is about the relationships that are essential for furthering public health, for furthering a strong client-patient or a patient-provider relationship, for thinking about institutional trust. I highlight this third piece because I think it can be forgotten as something that is critically important to public health and medicine. So I just want to let you know that I think these are kind of the three big buckets around communication goals. I'm going to be talking probably most about points 2 and 3. So if we're trying to persuade someone at a minimum to persuade them to pay attention, I'll talk about the attention economy here in just a little bit. So the talk is going to be more focused on points 2 and 3, but there's going to be a lot that's relevant for number 1 also. And one of the points that I want to start here with, especially when talking with people who've often been in school for a really long time, who have been trained that kind of knowledge is the only reason that people make decisions and kind of fact sheets are the primary way to get people information that they need. I want to present an alternative to how to think about more effective communication with people. What I'm going to share with you is taken from the EPA, and I know everyone is able to read, but I'm going to read it for you because I think this helps a little bit. So there'll be 3 sections. So many people start risk communication with the view that if they can just give their audience the facts, it will change their beliefs, attitudes, and behaviors related to a given risk. Okay, so this is known as the knowledge deficit model of communication. It is often called the knowledge deficit fallacy because most people are not empty buckets, kind of waiting for scientists, for physicians, for researchers to just tell them what to do, right? People are coming with experiences, they're coming with views, they might be armed with the research that they've done online for themselves, but people are not coming to a decision as blank slates, and there may be plenty of things other than just knowledge and facts that inform decision making, which mean we need to take a different strategy if those are the problems or if those are the issues at play. Okay, so decades of research from the psychological and decision risk and management sciences has shown that kind of this approach isn't true. Again, we're not empty buckets. We're not just ready for things that folks who have more education than us are wanting to share. So people make decisions for many complex reasons, and not all of them have to do with what a scientist, clinician, anyone might see as numerical factual risk. The good news is that there is also much research that points to the way to what does work. Now, I may be preaching to the choir here. This may be quite familiar. This might also ruffle some feathers. Again, if people have kind of been brought up in an environment where like facts and behavior feel like very closely linked, I would ask you to reflect on some of the decisions you make in your own life. And if just because we know things about how much salt we're supposed to consume, how many vegetables, how much exercise, how long we're supposed to be on our phone before bed, how much we're supposed to save for retirement, whatever it is, right? I imagine you know what you're supposed to do, but that information about what you're supposed to do might not lead to the decision that you're making, right? You've got other reasons that you're making the final decision. So what I've tried to set up in the slide here is that we are often really interested in people's behavior. So this is part of the decades of research from, again, the decision sciences, psychology, communication, economics, like a broad social sciences field, that if we are ultimately interested in behavior, and this can be at the individual level, this can be at the organizational level, this can be groups, this can be institutions, behavior writ large. And behavior also doesn't necessarily mean only an action. It can be how people think about things. There are many, many drivers of behavior. And you'll see on this list as you read through that knowledge is there. Knowledge is still important. It can play a key role, but there are a lot of other things at play too. So you could think about an example of seeking mental health care, right? So people's perceptions about whether this is a real disease, whether it is worthy of treatment, if it is associated with shame to go seek treatment, if there are community, family, or cultural norms around seeking treatment, and the stigma, that can have a huge impact on people's behavior. There are, of course, other external drivers like access to physicians, healthcare, cost, things like that. I'm not so much talking about those right now. I'm more talking about kind of individual and peer level perceptions, beliefs, attitudes. But these things can be shaped by how we communicate. And I'm not saying just because we communicate one time in a more inclusive way that it is going to suddenly change somebody's behavior around mental health care or protection from a vector-borne disease. But how we communicate can influence some of these internal drivers here. It can address people's fear. It can address people's sense of perceived severity or urgency. It can help address somebody's motivation or their self-efficacy. And so if how we communicate with people can influence some of these kind of moderators and mediators of behavior, then we have a better chance of, at some point, potentially seeing a behavior change. I need to say at this point that changing somebody's behavior is a really tall order. It is hard to do. Most people do what they do for a reason. It may or may not be something that you deem as a good reason, but in general, right, people are busy, they're tired, they're stressed, they're bored. There is a big hump of inertia to overcome for any kind of behavior change. And so if I haven't made an argument that's effective for you yet, I do want to try one more time to argue that I imagine that many of you, whether you know it or not, are actually quite interested in behavior and behavior change. Again, this might be patients, this might be clients, this might be various communities you work with. It might be something more like funding and wanting to make sure that your research and your work is funded, or that it gets media attention, or that you are interested in the extent to which people listen to you, trust you, the extent to which people go to your websites and social media, engage with you in other ways. These are all forms of behavior. It can also be how effectively your teams work. So I am really trying to make a behavioral argument here. And again, connecting the kind of how we communicate in terms of what we say, how we say it, whether we're saying something at all and it's in visuals, the language that we use can impact some of those middle drivers and ultimately lead to behavior. I will step aside for just a second and say maybe like you don't really want to deal with everything there in the middle, that it's too much. You're just kind of more interested in making sure that people can get access to the information and leave it there. That is completely fine. There is an idea called organizational health literacy, which is about the extent to which organizations make sure that their materials, their processes are equitably accessible, understandable, and usable across their different audiences. I think this can be really, really important in a time where not everybody is necessarily going online. Not everybody is going on social media. Not everybody has easy access to a patient portal. So being able to think about what this means in terms of access to our materials is really important. And I'm going to connect this back just to a second for the model. So again, even if thinking about stigma or fear or empathy, if that is not how you want to approach this, that's fine. But at a minimum, communication needs to be encountered, understood, accepted, used, and remembered. And you can put that in whatever order you want for it to be effective. And how we communicate has a pretty big impact on that, right? We can make the most beautiful website. We can give the best recommendations to patients. But if it's not shared or written down or explained in a way that people can understand, accept, and remember, it functionally doesn't matter. And then there can be consequences to trust and credibility with that. So I am trying to kind of let you engage with this or allow you to engage with this wherever you would like. If you want to get more into the details and the background, we can do that. If you're interested in kind of just strategies on how to make material more accessible, we'll be doing that too. So what I'm going to move into now is trust in medicine, public health, and I should add science and doctors, why it matters. So I imagine if I were to have this be kind of like a more interactive session, a lot of you would have things to say about how trust relates to your day-to-day work, right? Whether people are willing to talk with you, whether they're willing to consider what you have to say, whether they will come into the office or come to a meeting with you. It is pretty critical right now. I mean, trust has always been important. There's lots of research on the extent to which a patient trusts a physician on their healthcare seeking behaviors, their willingness to talk about sensitive medical issues. So I imagine this is an audience where trust is already understood as pretty important. What I would like to talk about is where we are right now in the US and internationally to some extent with declining trust. A little bit about why that is happening. We could have many, many sessions on why trust is declining. That's for another time. I'll just give you a couple of snapshots. But when we do that, we're going to be talking about potentially four different kinds of trust. And I'm just going to map that out quickly. So if we have sociologists or anthropologists in the audience, I apologize for an oversimplification, but I'm trying to make this as accessible as possible. So there's interpersonal trust, which is something that all of us deal with. So what is the trust between two individuals? This can be a work relationship. This can be a friendly relationship. This could be someone who's helping you with your car, whatever it is. So that's interpersonal trust. Organizational trust is within the context usually of work. So people who are working in an organization, this could be volunteers, this could be a religious organization. To what extent do people trust one another to act in each other's best interest? Is there trust in leadership? This can be very important for many different reasons. This is probably one we're going to be talking a little bit less about. Institutional trust is a huge one. To what extent do people who are interacting with an institution, a hospital, a university, a state or local health department, the US government, to what extent is there trust of that institution? And I think what can be tricky here is that there's kind of how an institution behaves, there's how members of that institution behave, and people can kind of conflate one with the other. I think what this maybe the take home point here is that we are often each ambassadors for an institution. That if we are a member of a university, a hospital, or whatever, someone's attitude about us can carry easily to the entire institution. Similarly, if people have had a problematic experience in some way with someone connected to the institution, that can kind of lead back to an initial assessment of who we are just because we're affiliated with that institution. And this is a really important thing kind of in this moment where there is, I think, extra levels of skepticism and distrust around anyone considered as part of the elite. And I'll hit on that point again in just a minute. The last dimension of, or I guess type of trust that we'll chat about is societal trust. So this is more of like kind of a general sense of, can others out there be trusted? And so what I'm going to do is go through a little bit of research on where we are in terms of kind of broad level institutional and societal trust as it relates to science, medicine, and public health. So that's basically what I just said. So the big picture here is that trust in medicine, or like those running medicine, and I realize that's a really broad concept, has been declining for some time. And so I think there's sometimes an idea that there has been a recent precipitous drop off, or that kind of that it wasn't all that long ago that there were really high levels of trust in medicine. And at least according to a couple of studies, that isn't the case, that for some time, trust in medicine has been declining for different reasons. In this chart here, it splits things out by political affiliation. Depending on your familiarity with social and behavioral science work, we often split things out by different categories. It is not trying to turn everything into identity politics. It's trying to understand trends and where there are things to pay attention to. So I just want to side that as opposed to like trying to further inflame issues around polarization. So there was a big around COVID, there was a big change in trust. So generally it was increasing among folks who identify as Democrats and generally decreasing among Republicans. Okay, so this is kind of big picture trust in medicine. When we get to some of the more granular levels, there are changes kind of across the board. So the good news here is that trust in one's doctor tends to be higher than almost all other forms of things related to health and medicine. So trust in one's own doctor remains quite high. What I am showing in this chart is the kind of decreases in trust across the board politically from June 2023 to January 2025. So this is from the Kaiser Family Foundation. This tends to be really high quality research. They have really strong methods. It is one snapshot and not a universal truth, but I think it's really helpful. So what this is showing is that kind of among those polled that there are declines in trust between these two time periods. So if we look at the top here, there's a decrease from 93% to 85%. You can see that once we start splitting this out by political affiliation, the differences are different. So Democrats were at a higher level of trust at the beginning and they lost less trust, whereas independents and Republicans had kind of a lower starting level and it went down. But we're still at around 85% of the population changing or trusting doctors. When we start to look at the CDC, state and local public health officials, and the FDA, we see pretty big declines. There are declines across all groups. There are, again, substantial declines in a pretty short period of time. So this is about an 18-month time period. Again, lots has changed since January 2025 even. So I imagine that this would look different. But we start getting kind of a really segmented view of where trust stands among different groups. And while I don't want to put people in boxes, part of what I'm going to be talking about later today is understanding your audience. And one thing to understand is what the background level of trust might be. And if it's likely to be low, then there is some trust building work to do. So it's on one hand trying to be aware of somebody's features of their identity that might indicate whether they'd be more or less trusting without assuming that that's true of any one person. So again, I imagine many people who are on the call today, none of this is remotely new, but I wanted to provide some data. So it's great news that people's doctors are a high source of trust. The challenges, again, as I imagine many of you know, access to primary care in the US really varies. In this graph on this map on the left, the states that are darker has the lowest density of primary care providers per population. The lighter blue has the highest density. So there are places like based on where you live, there's very different access to primary care. And then that can often very much, it varies not only by place, but by who has insurance. So access is tricky. So while it is great that doctors remain very trusted, if people don't have a primary care physician or can't get to one, then that source of trust is not really available. It puts more pressure than on other channels on the public health world to fill in that gap. So what I want to share now is a little bit about trust as it relates to scientists, right? So there's kind of building the argument that whether it's public health, medicine, scientists, there's declining trust. So this is a question about confidence in scientists to act in the best interest of the public. These polls started in 2019. This one was last conducted in October of 23. So again, a couple of years old now. There wasn't a more current one that I could find. The point here is that it's declining. The declines are sharper among folks who identify as Republican or lean Republican, but it is also declining among people who identify as Democrat or lean Democrat. So there's challenges there. What I want to get into now is a little bit, this is not specific to public health. This isn't specific to medicine or science. This is that domain of societal trust. And the take-home point here is that every generation born since 1940 is less trusting than the generation before it. So depending on who you're working with, the youngsters among your clients, your patients, your partners are likely to be the least trusting out of everybody you work with. Again, this is population level data, doesn't mean anything about a particular individual, but worth understanding. I teach a lot of Masters of Public Health students. I work with residents. I teach veterinarians. And one of the things that I say is just because you have these letters behind your name, does not necessarily mean that people are automatically going to trust you. You need to earn people's trust. I know sometimes people get quite upset about that because they have worked really hard. They want the moral authority to kind of be able to tell other people what to do. Unfortunately, the world doesn't work that way. And I'm sharing some of this to try to, again, try to help understand audiences about where some extra work might be needed and where some of the old assumptions about who is automatically trusted might not be at play any longer. This is breaking this, the same question earlier about the percent of people who can be trusted is breaking this down by different categories. So the things, what I'm going to show now on the left is that the more education people have and the more income people have, which are sometimes a proxy for one another, the greater the trust. Also like to point out that this is not a great scenario, that we're kind of topping out at 52% of folks feeling that others in general can be trusted. So I think this speaks to kind of a societal moment we're in. And so if you're working with audiences that have lower levels of education, that have lower levels of income, the likelihood of them being not as trusting is higher. Again, not a guarantee, but something worth noting. So this is the trends for based on age and gender. So there are lower levels of trust, as kind of showing earlier, in younger folks versus folks over 65. Again, still not maxing out particularly high. And there's lower levels of trust based on this study in women compared to men. And finally, there are different levels of trust based on racial identity. I realize it is problematic to put anybody in buckets and that this does not include all sorts of people. But for people who identify as Black or Hispanic, the levels of trust there are also particularly low. This is not saying that there is something wrong with anybody in any of these categories, right? There are likely good reasons why people feel this way. I am sharing it as a possible point of reference for thinking about who you work with and whether to assume that off the bat it's a trusting relationship or where trust repair might be needed. Next, what I'm going to share is how things have changed in terms of who is considered a legitimate voice on health. So this is from the Edelman Trust Barometer. This is a survey of, I believe, 15 countries, so the global 15, so 15 countries. It includes the United States, places in Western Europe, Latin America. So what this is trying to point to, I think, one is that this is not just an American experience, that the world is kind of changing in terms of who is a trusted source or a reliable source on health. And among the folks who were polled, there is still general interest. 72% of folks are finding that, academic training, having gone through medical school, nursing school, having received clinical training of some type, is still very important for being a legitimate voice on health, but it is not the only credential. The two other things that are following up quite closely are others who have a similar personal health experience. So whatever the health issue is that an individual is struggling with, someone else who shares that, their status, their influence has increased substantially since a decade ago in terms of whether they're considered a legitimate voice. Similarly, if people's advice has benefited them in the past, regardless of who they are, right, regardless of training, then they're also considered a legitimate voice. So this is changing the landscape on who the influences are, basically, on who is a source for advice. I think this is really worth understanding. I imagine many of you are experiencing this on a day-to-day basis in terms of ideas that people are coming into medical encounters with, or that they're bringing with them. I also think this can really help us understand some points for opportunity and what to do. The last thing that I want to share, and this is pretty much hot off the presses, this is about where people are likely to come across information. And I think this is really important because when there are new recommendations out there about colon cancer screenings, if there's new guidance around a Lyme disease vaccine, I share that because that's something I work on. This might be coming online later this year, depending on what happens at a federal level. any guidance about measles, right? All sorts of different kind of news items. Some people go out and look for that. I imagine many people on this call are considered high information seekers. I imagine you're reading news frequently, you're kind of like keeping up to date. A lot of people don't. And so this is a description from Pew about kind of where people, if people are deliberately seeking out information or they just happen across it. And one of the findings is that a lot of people, especially kind of those under 30, but even those under 50, are more likely to just kind of accidentally happen across information. And I think this is so important because if people aren't necessarily going to a doctor, if they're not going to hear about this on the news and the radio because they're not trying to stay up to date, it becomes really important that we figure out how to intercept people, how to reach people, because they're not going to go out and look for information, right? That it is much more likely that we've got to find a way to kind of like catch and grab their attention for people to find out about things. So I'm going to talk about those strategies a little bit later in the talk. Okay, so what do we do? Given that, there's loss of trust, we've lost influence, more and more people are a voice of legitimate health advice, and I cannot solve this problem, but I've got a couple of ideas that I think can help. And the very first one is trying to have an understanding of how people assess others' trustworthiness. And the star is here because if folks only trust you based on identity or shared group, so you need to be the same political affiliation, you need to be the same religion, you need to be the same skin color, right? There's not much you can do about that. It can be important to know. This is more kind of where for situations where there's room to move. And the first one that I'm going to share, well, I'll put all three of them up. Okay, so kind of the three main things that tend to rise as like main ways that people assess trust or that trust is built are by this sense of benevolence, right? So does somebody have your best interests at heart? Do they believe that you won't cause harm? And sometimes one of the most important ways to establish this is just how nice you are to somebody else. Like, how are they treating you? Are you coming to them with respect? Are you listening? That matters a lot. And sometimes those things, how you enter a room, how you start a conversation with someone, there are cues happening the second someone sees you and meets you, where people are starting to assess some of this. And some of this benevolence piece can show up before you have the opportunity to demonstrate these other two things. So competence and ability, I think goes without saying in the medicine, scientific, and public health fields is incredibly important, but sometimes people don't know necessarily how to assess this or know what this looks like if you're in a really sophisticated field. So this is, are you acting and operating with skill? Are you filling your commitments? Are you using the best information to make decisions? I think this is, again, probably a more familiar part of trust. The last piece is integrity. Do you do what you say you're going to do? If you say you're going to get back to folks with more information, do you actually do that? Are you keeping promises? Are you transparent? So what I want to emphasize with this is that all three of these things matter. I get the sense, just kind of, this is anecdotal, that there's traditionally a lot more value placed on number two and number three, right? That you need to be really good at what you do. You need to be transparent, like act with integrity. But the bit about kind of how we treat other people and the extent to which there's a deliberate effort towards understanding and trying for mutual respect, I don't think that has gotten as much attention. And I think can be really important in this time of hyperpolarization, where there is a lot of sensitivity, where there is a lot of judgment. These are things, thinking about how we treat others, that is a way to break through some of that. And becomes really important for like the larger public health goals, because trust ends up being kind of the foundation out of which everything grows. I like to think of it as like the fertile soil, and then other things can happen. Occasionally, right, you can have a really tough seed that grows in terrible soil and you can still accomplish things without trust, but things tend to flourish much better with a trusting environment. So I'm going to come back to the Edelman Trust Barometer, and so I'm just checking the time to make sure I'm staying on task here. So there was a lot of research that went into like, okay, well, how can we build credibility? How can we build relevance if academic training and kind of the more traditional credentials aren't working anymore? And there's lots of findings, but the one that I want to share, and I think the one that stood out kind of most consistently, and again, this is across many different countries, is that the more that you can show that you understand people like me, that you are really trying to understand the kind of core aspects of your audience's life and concern around the topic, the more likely you are to establish yourself as a trustworthy, relevant, and credible person. And I thought what was particularly interesting about this is that this largely held across age groups. Right? So whether folks are kind of in the 18 to 34 category or the over 55, there are small differences there, but this is largely holding. And it also is largely holding across political views. Again, this is not a silver bullet, as they say. This is not a magic wand. It's still only 66%, but this can go a meaningful long way or a meaningful way. Um, the other thing that I wanted to mention, and this is kind of a two-part point, is thinking about who's the messenger. So sometimes I've been on projects where it is best if I'm not the one who's going out and trying to engage with people, and that I either need someone to kind of vouch for me first to introduce me as someone who is very willing to be a good partner and is trying to like enhance capacity or solve problems that people are interested in. So I've either needed to be vetted by someone or I have a different messenger entirely, either because people don't feel great about the institution that I work with, that there might be something about how I appear that is not comfortable, or just simply that like I have not been working with or part of this particular group for a long time. So sometimes the messenger needs to be somebody else. And raising that as a question is an important thing to do. It might be right in a clinical encounter. It's just you. You can't change who you are. Like there is nobody else except you to be the messenger. But there are other times where like you have an opportunity to work with other folks who are more likely to be listened to by the audience you're trying to reach. And it is worth trying to connect with those folks and think about who those messengers are. If you'd like more discussion about this at some time, I can talk with you about that in a offline or in a separate session. Um, so one piece is, again, who is the person who's the messenger? The other piece is traits of influential messengers, and that is what these two scientists, so Stephen Martin and Joseph Marks, have put together, and their research is great. There's a wonderful article in the Scientific American. There's a great podcast. Again, you'll have access to the slides, so you can look that up. But one of what they ended up finding is that there are two distinct camps of there's two distinct trait sets of influential messengers. And there's hard messenger traits and soft messenger traits. The hard messenger traits, I think, are the ones that are maybe people have thought of as being the ones that these always work, these are the most important, right? It's about having status over the audience. So it's like you know more than them, you've got a better socioeconomic standing, you're maybe more dominant and combative. In some situations, like your attractiveness really matters. So in some settings, those are things that really matter. I think we can see examples of this in like different political spheres, different cultures where those traits can be really, really important. But the other thing they found is that soft messenger traits are equally, if not more important. And this is about connectedness with the audience. Okay, so being influential isn't the same thing necessarily as being trusted. And there are plenty of people who are influential and just have absolute junk to put out there. But this is all in kind of like the Venn diagram of working with people, getting their attention, and trying to connect. And so the point that I want to share here is that there are some of these factors in terms of soft messenger traits that we have control over when we're engaging with people in terms of how we show up. So the four big characteristics that they found were warmth, vulnerability, trustworthiness, and charisma. And while I know not everybody likes thinking about the concept of vulnerability, so I'm not really going to go into that. But how we show up in terms of warmth, asking about how people are doing, trying to establish some kind of connection, meeting with an audience where they are, if they're frustrated or they're angry, all of that can go a long way. Again, especially in an environment where I think there can be a rush to judgment that folks who have a lot of academic training, folks who have a lot of medical training, I think there can be a belief that's like, oh, they think they're better than me. And in this kind of anti-elite space, authentic efforts to try to connect with audiences can go actually quite well and can bridge some of that distance. I am not saying be fake nice, right? That is worse. But I think people can sniff that out pretty quickly. But these messenger traits do matter. Okay, so what I'm going to go, I know we are, I'm enthusiastic about this and I can talk. So I'm going to, in the last bit of this, kind of walk through features to understand about your audience and then leave you with some strategies and tools. So the first one, so the 6 things that I'm going to go over is, again, how trusting. So I'll go over that pretty quickly since we just talked about it. How ready to change is your audience, and are they looking for information? What do they care about? Because that's important for messaging. What is keeping them from doing what you want them to do? And I'm saying that like slightly to poke the bear, right? There are very good reasons why people might not want to do what you want them to do, but there's some really good social science work about trying to understand that so you can then bridge the gap. What are folks' literacy and numeracy levels, and what languages do they speak or read? So if you're not sure how trusting your relationship is with your audience, I think just assume that it needs some work, that those things that I was talking about in terms of really trying to understand your audience, working on that warmth and connectedness can go a long way. Okay, so that's just, it is worth asking that or considering this versus assuming because of my title, because of my credentials, I am trusted. You will know your clients, your audience is obviously much, much better than I and whether this is relevant. But for some folks, it's very much worth asking as a question. The next thing I want to talk about is how ready to change is your audience. And this can be about a promotion. This can be about partnering with you. This can be about changing diet. This can be about going to the gym, right? So this can be on all sorts of different topics. And the point that I'm trying to make here is that behavior is not like a zero, it's not a binary. It's like, it isn't that it's either happening or that it's not. There's a lot of things going on behind the scenes, and understanding how that breaks apart can really be helpful. I imagine many of you have already observed this in your work. I'm just going to try to give names to it a little bit. So this is called the stages of change model. I did not come up with it. It's been around for a long time. But the idea is here that you've got some folks that they are not, whatever thing that you want them to do, it is not on their radar, or they have already decided they don't want to do it. Contemplation, and so I'm going to use the example of going to the gym. And if any of you have heard my talk before, I'm sorry that I'm using this example again. But pre-contemplation is like, I'm not thinking about the gym. It is not a New Year's resolution this year. I've decided I'm not going. Okay, contemplation is like, I'm thinking about it. And you can add these time requirements here. This is more for like a measurement issue, but you don't have to add the time requirements that are listed here. So contemplation is like, I'm thinking, yeah, sometime I'm going to go to the gym, but I haven't done anything yet about it. Preparation is like, okay, I've got my gym membership. I've got a water bottle that is not disgusting. I've got my new gym shoes, whatever it is, but I still have not gone to the gym. Action, gone to the gym one time. Maintenance is that I'm continuing to go. Okay, so there are a couple of important things there. One is that getting someone from one stage to the next is an accomplishment. Getting someone to consider getting a colonoscopy is a big deal. Getting someone to finally consider things around smoking, around how they interact with their spouse, right? Around how they show up at work, whatever it is. Having that go from something that you're not willing to think about, from something you're willing to think about, is an accomplishment. Okay, so moving from one stage to the next is an accomplishment. The next point is that there's different strategies at each stage. If you get the slides, I've got details on what those strategies are. And the third really big thing is that if someone is in pre-contemplation stage or they're not really thinking about it, they are not looking for information. So if your strategy is to reach a bunch of people who are not interested in quitting smoking by putting up a website about quitting smoking or whatever it is, they're not going to go to it, right? Because they're not looking for information. And I think, so this is the details on what to do. Email me, I'll send you the slides. I think so there's a strategic communication class I teach for my students, and I think everybody comes into it thinking that like people are just going to be knocking down their doors wanting information and like desperate for what they have to say. If you are in that position, I am so very jealous of you, right? I think sometimes we're in a position where people really, really want to know what we have to say. They like want our specific advice. There's other times people don't want it. They're not interested in it. They don't want to be talking about whatever health issue we're trying to get them to talk about. And so in that case, you need a lot more proactive approaches to try to intercept people. Okay, the third thing to think about is what does your audience care about? Some people care a lot about health, but a lot of people don't. That is not their top concern. They care about finances. They care about not being in pain. They care about having time with family or enjoying outdoors or not worrying. And the reason this is important to understand is that if there's a way that you can connect kind of the larger public health or medical thing with what your audience cares about, you've got a much greater likelihood of getting their attention and having a conversation because you're linking to something that relates to them. So I've got my eye on the clock here. I don't think we're probably going to have time for questions at the end, but I want to make sure I can get through this. The next big thing is like, why is your audience not doing what you want them to do? There are more standard things about, do they think that they're susceptible? Do they think that the issue is severe? One of the things, or actually two of the things that are often missed is what benefits do people think there is to taking the action that you want them to take? Like, what is the good thing that is going to happen to them? How does this relate to something that they care about? People often don't connect their advice to that. And people often don't ask the like very real barriers that might be keeping people from doing something, even if they think it's relevant and important for them. So if you're able to communicate about understand what people think about the benefits and barriers to a particular thing you're wanting them to do, and there is a misunderstanding there, there's an opportunity to correct that. Or you can learn a little bit more about how to offer an intervention or how to make this situation work for them based on the reality of their lives. The last two things I'm going to go over fairly quickly. And the point here, if there's nothing else that you take away from this entire talk, is that about 50% of the US population, so above 18, so 18 to 65, cannot read above a sixth grade reading level. There's a whole other long discussion about that, but what the information that we put out with long sentences that's heavily, heavily textual, most people, there's a huge percentage of the population that can't use that. Their understanding of numbers is even worse. On the last thing, kind of an understanding your audience is trying to understand what language they speak. I know that people probably have a pretty good sense for language diversity in Chicago. There is a lot of diversity around the entire state. From a public health perspective, it is really important that information gets out to people in a language that they can read and understand. So if you're putting something out in the newspaper that's written in English, that's not actually for the general public, right? That's for people who can read English and happen to read the newspaper. So that's missing an awful lot of people. So what I'm going to whirl through in the last 8 minutes is strategies and some resources, and then I'll close with my email, and I'll really look forward to hearing from people, and I would be happy to have questions sent to me, and I can try to address those. So the very first thing is that less is more. In this attention economy where everybody's drowning all of the time in information, the more that you can make your point quickly and then link to better information or more information, the better. That way you're working with both the people who are just like, tell me what to do, and the people who are high information seekers who want to know all the details. So have the main points and then have links and information to other things. So less is more. The second thing is whenever possible, use visuals. This gets people's attention. It addresses a lot of those literacy and numeracy, or a lot of the literacy barriers. It ensures correct action, and it's just more interesting. So keep it short, use visuals. The third thing is if you're going to use charts and graphs, tell a really clear story and make the title the main point. A lot of people cannot interpret graphs and charts. They don't know what point you're trying to have them take from it. Includes highly educated folks because there's a lot of horrible charts and graphs out there. So the more that you can have your chart tell one main story and have the title be the main point, the more likely you are to get the reaction or the people are more likely to understand what you're trying to share with them. Similarly, if you're going to talk about any kind of number, so this includes percentages, lots of folks don't understand percents. They definitely don't understand odds ratios, risk ratios, absolute risk, relative risk. The more that you can visualize that, the more it's going to help people understand. This is a resource that a lot of folks have, I think, really enjoyed from other talks that I've given. I'm not expecting you to be able to fix everything on your own. Okay, so AI can really help. I know people have mixed feelings about that. I'm happy to provide some guidance on that another time. But there is a non-AI tool called the Hemingway app where you can put your material into your desktop. The app will show you what reading level it's hitting at and how to change your different sentences or which sentences need to be changed so you can get it down to that 6th to 8th grade reading level. The more that you can tell your audience like why it is worth their time to do what you want them to do, the better, right? So this is connecting back into things that people care about, again, because people don't necessarily care about health as a main priority. So what I've put on the right here are what are called universal motivators. So if for some reason you don't know the details about your audience, these things tend to motivate people. So if whatever you're suggesting will offer peace of mind or be a source of comfort or allow more pleasure, enjoyment, or freedom, those things tend to be motivating. And so this can be a good resource as you're thinking about how to present and frame some of your issues. The next is that if you're gonna scare people, so if you're gonna tell people about a problem or a thing that is bad, whenever possible, pair that with something that they need to do. So this might be more important for like the public health community out there. There's often like we'll say danger, there's ticks. And I'm giving just kind of a silly example of this here. There's a warning about ticks, but not about what to do. Often what this means is that people ignore the message, it freaks them out, or it shuts them down. And those are not getting you towards people actually taking care of themselves. So let people, if you need to let people know about something that is problematic and scary out there, you've got to pair it with what they need to do. Otherwise, they're just kind of going to ignore the message. And the last piece, and this may or may not be relevant depending on kind of the problems and the audiences that you're working with, but considering different formats from kind of websites and social media. So having listening sessions, doing a podcast, going on a call-in show, if there's a kind of a major local public health or medical issue. Okay, so what I'm going to end on, and I'm sorry that that we don't have time to chat. I'm going to share just a couple of tools and resources, and then I'll end with my email. So if you don't have a designer on your staff, I would highly recommend, if there's budget for that, trying to budget for somebody. If that's not an option, there are 2 really great resources. I have no formal connection to these. I've just seen students and colleagues have lots of success with them. So Canva is one. PictoChart is another. It also has some really great resources about visual storytelling, how to tell stories with data. So these are great resources. If you are really interested in science communication, there is a free book written by a colleague of mine. It's a science communication guide for scientists. It is wonderful. It has hit on many of the different things that I've talked about. So there you can look this up, or again, you can get the slides and click on the link. So just here's a sense of what's on there. And then last but not least, I want to end with a podcast that is fantastic. It's the Why Should I Trust You podcast. It's about why trust has broken down between the U.S. public, scientists, and public health community. It has folks who are journalists, virologists, skin cancer. There's a skin cancer surgeon. It is an excellent and thoughtful discussion. There are people from across the political spectrum. I think it is really doing a lot to try to reconnect people and understand different viewpoints. Highly relevant. And so I am going to end with, again, my contact information. It was so lovely to be able to spend a brief hour with you today. And so I am happy to address questions via email. If people are involved in teaching strategic public health communication, I'm happy to share my course design if that would be useful. I've got some thoughts and resources on AI and communication. And I also have a bunch of students and graduates who are looking for projects. So if there is a communication issue that you need some help moving forward on, I would be happy to connect you. So thank you so much for your time. I look forward to hearing from folks. And again, thank you so much to the organization for inviting me here today. All right, thanks everybody.